Welcome everyone to our 8th virtual meeting in our 2021 meeting series. And tonight we have Dr. Eric Wallace with us talking about Fabry disease in the kidney. And it's such a popular topic with the Fabry disease community that this should be a great talk. And as always, we have Dawn as my co-host and moderator. And what the agenda is for me to say a couple of words about Dawn. Dawn will formally introduce Dr. Wallace, because she does a better job with that than I do. And then Dr. Wallace will speak. We'll do some questions and answers, and then we'll do a few announcements, and then we'll do the prize drawing for the primary attendees, the people with Fabry disease, caregivers, and family members. So with that, Dawn Laney is with us again, and my reliable co-host. And Dawn is from Emory, as most of you know. Has a master's degree, and she's a certified genetic counselor. And Dawn she has many hats, and she is an assistant professor, clinical researcher, the program leader of the Lysosomal Storage Disease Center at Emory, and the director of the Genetic Clinical Trial Center at Emory. She also is the co-founder of Think Genetic. She's written and contributed to lots of medical publications, and Dawn writes children's books for fun. And so if you look on our website, you'll see Dawn's very interesting, very cool children's books about children with Fabry. So thank you, Dawn, again for being here, and thank you, Dr. Wallace.
Thanks, Jerry. As always, a lovely introduction. I'm very excited to today introduce Dr. Eric Wallace. You probably all know him. He has been in the Fabre community and working hard to help us unravel the mysteries of the kidney for many years now. He's also the medical director of telehealth at UAB, and he also co-directs home dialysis and UAB Home Dialysis Center. But most of all, he has really been a great partner in the Southeast, working with patients with Fabry disease. And it's been a pleasure to work with him on some people who, like our border babies and newborn screening, cross between Emory and UAB a lot. So with that, I bring you Dr. Wallace.
Well, thank you. I love the fact that this meeting is, has 19, there's 19 participants. So I mean, this is great. So if you just want to unmute and ask your question, you can, do it in the middle of the talk. I like things to be much less formal. The other thing you can do is I have my chat open. So if you don't want to unmute, just put a question in the chat, but do so real time. You don't have to wait until the end. I'm going to talk about Fabry disease in the kidney. Let's see if I can get my slide too. So I have to say, these are all my disclosures. So I tell people that pretty much if you're doing anything with Fabry disease, I'll work with you. And these are all the companies that are doing things with Fabry disease. We're lucky we have a very large Fabry population in Birmingham because Dr. David Warnock was my mentor. He's a nephrologist and was the first person in the United States to put somebody on commercial enzyme. So that was back in 2003. So he built up a large patient population. Him and I bonded when I was in residency. And then when I decided to take the job at UAB, Alabama's home for me. So it was a no-brainer to come back home. So he said, hey, you want to do Fabry disease? And I said, sure. And that's where this story started. So that was, I can't believe it. That was 9 years ago. So now I've been doing this for 9 years on faculty. And really it's expanded not just with Fabry disease, but other rare genetic kidney diseases because of the approach that we learned from how to approach the kidney and Fabry disease. So what we're going to talk about here is, first of all, why is the kidney important? I think a lot of times in the talks that I've been to, we start with all the data, and I don't know about you, but I can't sit through talks that's just paper after paper. So I start with, what's the kidney? How does it work? How do we measure the effects of Fabry? And then really, what can we do to keep the kidney function? This is just what my patients ask me. They just want to say, how can I keep it from getting worse? So I'm sure that most talks have this slide or a slide similar. So, Fabry disease stems from this deficiency in an enzyme. So that enzyme is called alpha galactosidase. And think of alpha galactosidase as like acid in your stomach, right? So the lysosome is like the stomach of the cell. And what's supposed to happen is you're supposed to put stuff in it and it's supposed to degrade, right? And then you actually export it in these things called vesicles. So vesicles then go to the edge of the cell, it dumps it in the blood vessel, and guess what? We pee out that stuff, or we get rid of it in many ways. So if there is no acid in the stomach, well, things don't break down. And so in this case, alpha galactosidase is deficient. So the stuff it breaks down is this this protein, or it's actually a sphingolipid called globotriacylceramide. Depending on what you're reading, it's GB3 or GL3. And so since that GL3 and GB3 doesn't break down, it builds up and these lysosomes get huge. And we all know how we feel when our stomach is completely full and isn't going away. Well, that's how your cells feel, is they do not function that well. Unfortunately for your cells or patients who have Fabry disease, these cells have been building up this substrate since birth. So they get bigger and bigger and bigger inclusions, and eventually that leads to cellular dysfunction. Now, organs, so if one cell doesn't work, no big deal, right? But if the sum total of all the cells in an organ don't work, now you get organ dysfunction, and that leads to the pathology that we see, like kidney failure, stroke, that's largely from the blood vessel disease and accumulation of GB3 in the capillaries, heart disease. People get GI manifestations, peripheral neuropathy, headache, there's anxiety, depression, all of that is all secondary to this buildup. And it's all secondary to Fabry disease. So who cares about the kidney? Why is it important? And it turns out the kidney's job is really just to maintain balance. Actually, the kidney is, our body is designed so that whatever stuff we put into it, bad or good, the body, specifically the liver and the kidney, actually metabolize them. It keeps what the good stuff is and pees out the bad. That's why people who have relative or normal functioning kidneys can drink whatever they want, right? We can drink up to 18 liters of water a day and our kidney would just pee it out because it'll say, hey, look, you don't need 18 liters of water. We could drink 15 or 2 gallons of orange juice, which is loaded with potassium, and we would just pee out the orange juice, right? We'd pee out the potassium. We'd only keep the potassium we needed. Same with sodium, etc. So the other thing it does, so it keeps balance. So the things that it's trying to balance is toxins. So as your cells metabolize, as your cell work, they make trash. And we got to get rid of that trash. And some of that trash is called urea, which is nitrogenous waste product. So it's supposed to pee that out. Removes water. So, our body can only hold so much water. If we didn't have kidneys and we drank a bunch of water, we'd blow up like a balloon. Eventually it would get to our lungs, and then we wouldn't be able to breathe, and essentially we'd drown. And unfortunately, this can happen in patients, for instance, who miss dialysis for months and they don't watch what they're drinking. They basically fill up with fluid. So kidneys can do that. It regulates blood count. So people don't necessarily know this. Everybody associates the bone with making blood, and that's true. The bone makes blood, but something has to tell the bone marrow to make blood, and it turns out that's the kidney. So the kidney has these little sensors in it that says, I'm getting enough oxygen. If those cells are getting enough oxygen, they tell the bone marrow, hey, I don't need any more blood. If they're not getting enough oxygen, it says, hey, bone marrow, please make more blood. And that's why as the kidney fails, usually the blood count goes down too, because that process, that loop doesn't actually occur. It regulates bone metabolism. So the kidney actually is responsible for making vitamin D. Jerry asked, are people with kidney disease commonly anemic? And yes. And when I say kidney disease, most of the time you have enough of this signal until you get to about chronic kidney disease stage 4, which is a function of less than 30. So, even as your kidney declines, starting below 30, people start to get anemic. So it regulates bone metabolism. So it's responsible for activating vitamin D. So we get vitamin D from the sun and from what we eat, but that vitamin D is pretty useless. The kidney has to activate it, and it does so based on your calcium levels. So you need, don't get me wrong, you need vitamin D. And actually in our clinic, we check vitamin D on everybody, and we have found a lot of vitamin D deficiency. So nutritional deficiency. So then your kidney activates it. It says, hold on to calcium. The calcium goes to your bone. So that's how the kidney regulates bone metabolism. And then it regulates blood pressure. So it does a whole lot. The kidney's responsible for a whole lot. There's two tiny little organs. They're about the size of your fist, but they do a whole lot in the body. So how does it work? So it turns out the kidney is just like a pool filter. I mean, literally, I tell my patients that I'm the cool guy, because what happens is that you have bad water. So the bad water comes in via the renal artery. It goes to this filter. Something happens in the filter. Clean water back to the pool, and the pool up at the top. If the filter is not working great, you get the pool at the bottom. Well, in this case, the pool is your blood. You don't want your blood to have all these toxins in it, right? So this is how the kidney looks. So like I said, it's about the size of your fist. And you have inside the kidney these things called glomeruli. That's what's on the right-hand side. And these glomeruli, there's about 1 million of these glomeruli in each kidney. And the blood's into them. And they're blood vessels that work like a sieve. I'll tell you, this. So think about when we're making mashed potatoes, right? You boil a bunch of potatoes, and then you take the water and you dump it into a sieve. And what should happen is the big stuff should stay on top. The water should go into the sink, right? Now, if you have a hole in your sieve, well, the big stuff goes into your sink, right? That's exactly how this works. So, can you guys see my pointer? Yeah. All right, do you see where the capillary lumen is? That is the top of the sieve, right? And the big stuff in there is blood vessels and protein, right? Now, what happens is that gets squeezed, in this case, up through the glomerular basement membrane into the urinary space. And what should happen? Blood cells and protein should stay down here. And then up here in the urinary space should only be fluid, right? That's it, right? That's exactly how it works. It just strains your blood. So if there's a problem, like in Fabry disease, what happens is the sieve doesn't work that well, and protein and blood get into the sink, or in this case, the toilet, right? It's really that simple, all right? So how do we measure the effects of Fabry disease on the kidney? All right, so there's a couple of things that everybody should know about the kidney itself, right? Which is, it turns out the gold standard for measuring kidney function is this thing called creatinine, right? And if you don't know your creatinine, you should know your creatinine. Not only should you know your creatinine, your kidney function. Now, creatinine, as it goes up, the kidney function is going down. So the higher that number, normal is anywhere from about 0.6 to about 1.2. Now, I say that really kind of tongue-in-cheek because it turns out that creatinine is really based on muscle mass. So if you are a small female, and even though the normal value is 1.2, if a small female has a creatinine of 1.2, I think this patient has kidney disease, right? Because if her baseline was 0.6 and now her creatinine is 1.2, it's doubled, which means she's lost about half her kidney function. On the other hand, if you have a bodybuilder, right, who has a ton of muscle mass, 1.3 may be normal because they have a lot of muscle mass. So you got to take it with a grain of salt. Now, it is important to know your creatinine, but more important is to know your GFR or eGFR. This is called the glomerular filtration rate, right? So normal is 100%. As your kidney declines, oh, can you hear me? It says I'm breaking up.
It is a little, it's
Am I
going
still
in and
breaking
out.
up?
A little bit, not much.
Okay. I'll try. I'm not sure. Maybe it's the weather. All right.
It's better now.
Okay. If you want me to repeat something, just put it in the chat, because unfortunately I can't hear myself breaking up. So the glomerular filtration rate takes the creatinine and then looks at the patient's age, race, and sex. Now, race is hotly debated now whether or not we should even have that in this equation, but for right now it is. So what this will do is spit out a number, and you can say my kidney function last time was working at 75%. Now it's working at 72, 71, and you want to know the general direction that your kidney is doing. So I would ask, I mean, everybody with Fabry disease should have their creatinine checked at least once every six months, minimum once a year, but once every 6 months would be better. They can put this into the equation, and then you can graph your kidney function over time, okay? As I discussed, females in general will have lower creatinines than males, even at the same level of GFR. So GFR is a better measurement, okay? The other thing that we measure with kidney disease is protein in the urine, right? So what we want to know is how many holes in the sieve are there, right? So the more problems with the sieve or the glomerulus, the more protein will be in the urine. And there's other things that are more experimental, like podocytes in the urine. That is not available clinically, at least in the United States, where they can actually look at the cell that is responsible for the sieve and say, is that in the urine? Okay. All right. Any questions? So really important to know the slope of your kidney function over time. All right. Now, unfortunately for us, kidney docs usually get involved when there's loss of GFR, so loss of kidney function. And the reason is that internal medicine docs, geneticists, a lot of times don't recognize or they say, look, I don't need a kidney doc because the kidney function is normal, so I don't need a kidney doc. Unfortunately, a lot of kidney docs don't want to be involved unless the kidney function is abnormal. But if you look at this timeline, right, look at where loss of GFR happens. The loss of GFR is actually pretty late. So by the time you have loss of GFR, you've had years and years of first you get the deposits in the podocytes, then you get effacement of the podocytes, which is where the podocyte itself starts smushing. Then you start losing podocytes in the urine and need a little bit of protein, and then you lose GFR. So by the time you lose GFR, it's been going on for a long time. And so there's a lot of things that happen before you lose GFR. Okay. So what can the kidney tell us about Fabry disease, right? And so the real thing that we use kidney biopsies for is we use it to tell us a lot about Fabry disease, all right? So first, I like to tell people about a kidney biopsy. Some people may or may not have had a kidney biopsy, but let's talk about the procedure. So the procedure of a kidney biopsy is the kidneys are in the back, right? And they're actually really close to the back. So when you do a kidney biopsy, you will lay flat on your stomach. Usually people are awake for these, and the reason they're awake for it is because the kidneys are right underneath the diaphragm. So every single time you breathe, the kidneys move. Well, you don't want somebody stabbing your kidney when it's going like this, right? You want them to be steady. So usually what happens is that we ultrasound the kidneys, and we don't tell you which one we're going to go for. We just go for the easiest one, because whatever is going on in one is going on in the other, okay? Then what happens is we numb the skin on the back. Then we take the ultrasound, we guide the needle to the kidney, which is probably about that far down. We numb the outside of the kidney. The kidney itself doesn't have any nerve fibers. but the surrounding layer does. So we numb that up. And then we take the biopsy needle down to the kidney and we say, on the count of 3, hold your breath. So we go 1, 2, 3, you hold your breath, kidney stops moving. We press a button, the needle goes in and out and takes a core, right? Usually we do that 2 or 3 times because if we got you there, we don't want to bring you back, right? We don't want to say, hey, we didn't get enough. Why don't you go through this again? Nobody would really want to do this multiple times if they could help it, right? So the risks are real. So, we always want to say, would we do this every single time? Because if I do 10,000 kidney biopsies, somebody's going to have an issue. And so what are the issues? The kidney is a big sack of blood vessels, right? And so if I poke a hole in a sack of blood vessels, you think that the biggest problem is going to be bleeding, and that's what it is. So the risks are bleeding, bleeding, bleeding. So everybody will have a little bit of blood in their urine. That's normal. So actually, if you don't have blood in your urine, you need them to go back and get some more tissue because they probably didn't biopsy kidney. But about 1 in 1,000 patients will actually bleed to the point they need a blood transfusion, right? It's actually about 1 in 1,000 to about 1 in 5,000. Now, it turns out that that's not fully true, because if you look at the people who bleed and need a blood transfusion, it's usually patients who start at lower blood counts. Now, I already told you that most people with chronic kidney disease have low blood counts to begin with, right? So if you start at a blood count of 9, a hemoglobin of 9, and then we biopsy you and you bleed a little bit, well, you're going to need a transfusion. If you start at a blood count that's higher, it is far less likely that you have any issues. The other thing is that if you have severe kidney disease, you are more likely to bleed than if you get biopsied at a normal kidney function, right? Or much better kidney function. And the reason is that kidney disease causes issues with the blood vessels. Arteries, when you biopsy them, should just be like elastic and they should close off. But in advanced kidney disease, the arteries become like PVC pipes. So when you biopsy them, they just get stented open, right? So although there are risks, the risks are mitigated and are much less in patients who don't have severe kidney disease and have relatively normal blood counts, right? It doesn't mean they're zero, but they're better. Now, as far as the benefits all happen to have to do with what can we learn from a kidney biopsy about patients with Fabry disease, right? And really, what people can learn from this is so let's talk about variants, right? So there's patients that are being identified now because genetics have gotten cheaper that have variant mutations or late onset mutations. Well, it turns out sometimes when we have variants or late onsets, we don't know what they mean. We just know you have a mutation, but what does that mean in the tissue? So one way to do it, we could just start everybody on therapy. But starting everybody on therapy, I don't know how many people are on therapy, but going to an infusion for 4 hours every 2 weeks for the rest of your life, if you didn't have to, is not ideal, right? And so what we want to know is, well, how bad is this variant mutation in the kidney? And is it enough that you have to have therapy, right? And so that's one thing we can know, right? Now, females are even more difficult, right? So females, classic or non-classic, right? So we have sisters that they have the same mutation. One of them has severe disease. One of them doesn't have any disease. So why is that? And I'm going to go through some cases. A biopsy can actually help in females because females are really difficult when it comes to judging therapy. Females are not carriers. There are many females that have every bit of severe disease as males, but there's some that don't, right? And once again, before we say, infusions for the rest of your life, we want to know, right? Scarring and prognosis is also important. So we found that if you do a biopsy and you have greater than 50% scar in the kidney, because we not only get to look at the glomerulus, we get to look at scars. So if you have greater than 50% scar, you are more likely to progress, even if you're on therapy. That doesn't mean you don't need therapy, but it does mean that the likelihood of progression is much higher if you start therapy with already advanced disease. Insurance is another more practical one. So I know we have somebody from Germany, so hopefully you don't have this issue, but I went, there was a time where insurance just told us, they stopped 4 of our female patients. And their reasoning is that we have this biomarker called Lysogl3. And Lysogl3 is very good for diagnosing patients, but it's not very good for following them, right? So we had an insurance company that said, hey, look, we're not going to pay for anybody whose Lysogl3 did not get better on therapy. But luckily I had a kidney biopsy to show these, that the insurance company, I said, look, I don't care what their Lysogl3 is. I have a kidney biopsy. This is what it is. You can't stop the therapy. And I was able to salvage the payment because we had a kidney biopsy. And then finally, there's other things. So Fabry disease is pretty rare, but there's a lot of other things that cause kidney disease. So what if we miss an actual cause of kidney disease? What about a secondary cause of kidney disease? That could not be Fabry disease, a secondary thing. And that's been reported in the literature. All right. So this is what happens when we get a kidney biopsy. So see, the kidney biopsy shouldn't have, see all this black stuff? There's one of them that looks like stripes and one of them looks like circles, right? So stripes, and all this is it's how you slice an onion. Literally, that's what it is. So if you slice an onion this way, it looks like stripes. If you slice an onion this way, it looks like whorls. So these are called zebra bodies, the ones that are striped, and the other ones are called whorls. Either way, they're the same stuff and they shouldn't be there, right? So these things are abnormal. Now, so let's just take a couple of cases. So we have a 31-year-old female, family history of Fabry disease. Luckily, we do a lot of family screening to make sure we identify everybody. So she has a little bit of pain in her hands and feet, but it's just in the summer. And, you know, summers in Alabama get to be, 105. So denies angiokeratomas, no skin lesions, no GI. She does sweat. So this is what we call oligosymptomatic. She has pain. Now, there's other things that cause peripheral neuropathy too. So how do I know that the Fabry disease is causing her neuropathy? It's probable, but what if I get it wrong? What if there's something else? So we did genetics on her because we were taking care of her father. Classic mutation identified, right? So she has real deal genetics, right? That show that this is Fabry disease with a classic mutation, right? Now, so we do a full baseline evaluation. Her cardiac MRI showed normal LV mass, no late gadolinium enhancement, means the heart is fine. The MRI of her brain, we do that on everybody, no white matter disease. So we have a normal heart, we have normal brain, kidney function. Her creatinine is 0.8. Her kidney function is normal. GFR is 99. That's normal. And we did a 24-hour urine looking for protein, which is kind of your gold standard. And everything was normal. Okay. All right. So is everybody hearing me okay still? All right. So what would you do with this patient? All right. Now, I mean, for us, it wasn't that easy. So we had a patient who had her entire baseline evaluation was normal, except for a little bit of pain, right? So what do you do? And so what we did, and what we do specifically with females, is we do a kidney biopsy. And this kidney biopsy was chocker block full of inclusions. And you can see all this dark pink stuff should not be there. I mean, this is one glomerulus. And it is chocker block full. 1 minute, somebody asked a question. All right. So this is electron microscopy, and you can see also has a lot of lysosomal inclusions. And so in this patient, now we had real reason to start enzyme therapy, because when the kidney looks like this, we know that the rest of the body, the rest of the organs also likely have this. And so even though she had normal LV mass, she had normal MRI of her brain, normal everything, right? except for the pain, and now we had a kidney biopsy. So this was really important in saving this patient's enzyme, because I didn't care what the lyso-Gl3 was. I cared that I had histologic evidence of damage. All right. So let's talk about another one. So asymptomatic female, right? So this is a 23-year-old, family history of Fabry disease. Her mom had Fabry disease. Her mother had progressive kidney disease and an enlarged heart. So mom has real severe Fabry disease, but this is her daughter, 23-year-old. Now, GL3, we did the same thing. Genetics, patient has genetic with a classic mutation. GL3 and lyso-Gl3 are undetectable. Cardiac echo is normal. MRI, no white matter disease. So perfectly normal, right? So in her case, do you start therapy? Yes, no. Well, I just gave you an example of a patient who had the exact same presentation with some pain, and her kidney biopsy was chock or block full, both with classic mutations, right? These are not variants. We did kidney biopsy on this patient, 0 inclusions. Now, I'll be honest, I've never seen a biopsy that had 0 inclusion. I've seen little, but this one had none. So now we could say to this patient, look, at the bare minimum, you don't need therapy right now. Why don't we wait? I'll follow you every single year. We'll follow how you're doing. If anything turns around, we'll do a kidney biopsy, a repeat kidney biopsy. But we'll be following, but we will not start therapy at this point. I mean, there's just nothing here saying we need to do it, right? So why this variation? Two females, very similar presentations, but one has significant histology, one doesn't, right? And it turns out you can see this in sisters, right? So, and what it has to do with is this thing called skewed X chromosomal inactivation. So females have 2 X's, and you don't need 2 X's. So you say, so Jerry's asking, was her enlarged heart due to LVH? And Jerry, yes, that patient's mother was enlarged due to LVH from Fabry disease. So X chromosomal analysis, so you don't need 2 X's, and what your body does is it inactivates 1. So it just randomly chooses 1 X chromosome and says, look, I don't need that. So it should be random, which means that 50% of your cells should inactivate the Fabry chromosome, X chromosome, because Fabry disease is X-linked. 50% should inactivate the non-Fabry X chromosome, right? Now, but what if you inactivate, what if you're a female and you inactivate 80% of your Fabry chromosome? Well, now most of your cells, almost all of your cells, have only the X chromosome without the mutation that's active. So on the other hand, if you inactivate 80% of the good or the non-mutated X chromosome, then 80% of your cells have the Fabry activated. And so you look like a severe male, right? That's why there's all this variation. And it turns out there's a phenomenal researcher by the name of Dominic Germain in France who wrote this paper, and he looked at females and looked at the skewed X inactivation. And if you can see this, the very bottom line, that's the worst GFRs. It turns out it was perfect. It was for the worst GFRs were in females who were skewed towards the Fabry chromosome. So most of their cells had the Fabry chromosome activated. The dotted line, which had the best GFRs, were females who were skewed towards the good chromosome or the non-mutated chromosome. Don't mean to say good, it's non-mutated, right? So, and then those in the middle had random, so it was literally 50-50. So that explains the phenotypic variation in females, and only one of many things we can learn from a kidney biopsy in these patients. So now in classic males for kidney biopsy, that's something I get asked a lot. And if you're a classic male that has all the symptoms, do you need a kidney biopsy? And the answer is maybe, maybe not, right? There are classic males who you just say, look, there's so much here, we're going to start therapy no matter what. On the other hand, the hope is as we get more and more treatment options or therapeutic options, what you're going to want to know is what the baseline is. So, there are studies out of Norway where what they do is they do a kidney biopsy every 5 years. So you start with X therapy. 5 years later, you say, have I progressed? So you get a kidney biopsy. If you progressed, well, we change your therapy or we add a therapy on, right? 5 years later, you get another kidney biopsy. So if we get to the point where we have multiple therapeutic options, routine kidney biopsies and understanding the baseline will be important. In the United States, where we have one therapeutic option for classic mutations, we have two for amenable mutations. That's a different question. So the next thing we ask is, how do I keep my kidney function stable, right? And it turns out this is a paper that I wrote looking at all the advances or all the things that are being tried currently for Fabry disease. And it's really exciting to be a researcher in Fabry disease right now. So let's just talk about all the things that can happen and where we can intervene. So this is a genetic disease. So what if I intervene at the level of DNA, right? And it turns out there are currently 4 companies that are looking at this. Which is gene therapy. So one of them is AvroBio. AvroBio is a company their gene therapy takes stem cells out of your body, infects those cells outside of your body. So the hematopoietic stem cells actually have the gene. Then they ablate the bone marrow. So the bone marrow has to be clear to accept the stem cells back. They infuse the stem cells back into you, and now you have a population of cells that have the good gene. All right. So Sangamo has ST920. Freeline Therapeutics has FLT190. These are adeno-associated viruses. Actually, I believe one's adeno, one is lentivirus. And no, these are both adeno-associated viruses. They target the liver. So the liver is a huge organ. So what if I infected the liver? Now the liver cells start making a bunch of enzyme, and now I don't have to have enzyme anymore, right? Because I make it internally. And then finally, there's 40MT, which has a virus that targets cardiomyocytes, because one of the things, the cardiac cells don't take up enzyme as readily as other cells. So this company said, look, one of the unmet needs is the cardiac issues. So why don't we actually have cells take up virus inside the heart? The heart cells will make their own enzyme and then extra, which will go into the bloodstream and hopefully make things better, right? So very excited about gene therapy and the advances that can come. So the next thing that hasn't been tested in humans yet, but has been tested in mice, is mRNA or nanoparticles. So DNA, has to be transcribed into RNA, right? So what if I bypass the DNA and I just started at the RNA? And it turns out this is how our vaccines for COVID are. They are mRNA wrapped in lipid nanoparticles. So now the problem with this is that mRNA is not very long lived. So the question is going to be when we start, because we will start trying it in genetic kidney diseases, this administration of mRNA. Will it be long acting enough, or will we have to just keep on infusing it? But an interesting concept, which I think got a big boost with COVID, actually. So after you get the mRNA, you have to translate the mRNA into protein, right? And protein, right? So this is mRNA gets transcribed into this slew of amino acids. Those amino acids is just a long line of amino acids, right? But they have to fold, right? So sometimes there's some mutation that keep this protein from folding, and that's a problem. So chaperone therapy actually helps with the activation energy to fold it into the right conformation. This is good for amenable mutations, right? Now, finally, what if I just bypassed all of that? Just give you enzyme. So we currently have 2 enzymes, which is Repligal and Fabrazyme, but there's some investigational products that are currently being tested, such as Protalix. So we are awaiting the results of the BALANCE trial, but Protalix would fit right here in the alpha galactosidase, just bypassing and just giving exogenous enzyme, right? Now, finally, there's one other way to approach this, which is, if you have a household and you have a trash can, right? So the lysosome being the trash can, one way to prevent the buildup of trash is to take it out more frequently, right? That's what enzyme does. It takes out the trash, right? But what if I just didn't make the trash, right? What if I didn't make trash, so I didn't have to take it out? Well, that's being tested with two drugs. One is, the company is Idorsia, and it's called lucerastat, and the other is venglustat. All right, so these are two different substrate reduction inhibitors. It's a concept that has been tried in Gaucher disease successfully. So now we got to figure out, does this work in Fabry disease? So I got a question. It says, how similar is this mRNA process to the mRNA spike protein one? Is this also same DARPA tech? So mRNA, that's an interesting one. So mRNA, you can make mRNA from any part of your DNA, and we have 20,000 genes in our body. So the mRNA that is made can vary infinitely, right? We can make mRNA that doesn't even exist just by stringing together these base pairs. So this would be completely different than the spike protein, right? So the spike protein, basically what they did is they coded the spike protein. They said, what are the string of amino acids that are needed to make the spike protein? They strung those RNA base pairs together and said, this is what the mRNA we're going to give. In this case, what we would do is we'd say, what is the mRNA needed to make alpha galactosidase? And then we would give that. So same technology, right? Meaning that it's the same base pair, same mRNA. You can't just infuse mRNA because the body would chew it up. The body's fantastic at chewing this stuff up, right? So that's why they have to wrap them in these lipid particles, right? So they wrap them in lipid particles so they can get delivered into the cells, they get taken up, and then hopefully it can start making alpha galactosidase. So similar technique, but different mRNA completely than the spike protein, all right? So enzyme. So Fabrazyme is now FDA approved. I think that happened in March of this year. If you guys don't know, we have a lot of ties to COVID here, but it turns out that Fabrazyme got approved on a temporary, on an emergency basis, and a lot of these drugs for rare disease get approved on temporary emergency basis because of the need for them. Right. And so just like the COVID vaccine was also approved on temporary emergency basis. But what that implies is that the FDA says, okay, well, you can use this drug, but we want you to collect data. And that's what Sanofi had been doing for years. And finally, there was enough data that amassed that they actually got their full FDA approval. Replagal is not approved in the United States. That's approved in other countries. And then chaperone therapy got approved in August of 2018 for amenable mutations. And once again, there's a lot coming down the pike, none of which we know is effective yet. We have to wait for the data, but I'm excited that people are trying things for Fabry disease. All right. So this is data on ERT on Protalix. So the bridge study was a single-arm switchover study. 22 patients were enrolled. This was a study done, it was a rollover study from Replagal to Protalix. And so what happened was these are patients who were on Replagal for 2 years. You see their slope on the right. Their slope of EGFR was negative 6.8. After being switched to Protalix for 6 months, their slope changed and was greater than 3.7. Now, the thing is that this was interesting data, but the dose of Replagal versus the dose of Protalix was completely different. So I think people are excited about this. I'm excited about this, but we're all waiting for the results of the BALANCE trial to see. So to see what the results are. That's really going to be the thing that seals this. So Randall asked, what about Galafold? Galafold is megalostat. So when I talk about chaperone therapy, I talk about megalostat. That is Galafold, right? So that was in that pathway where it goes RNA gets translated to protein, protein gets folded, right? And chaperone therapy helps that. Chaperone is Galafold, Galafold is migalastat. All right, so this is migalastat. So this is data on migalastat. This is a 3-year follow-up study. And so what you can see is that really the take home from this graph is that migalastat in the group that it was tried on did tend to stabilize kidney function. Now, migalastat has less follow-up than enzyme replacement therapy, but has about 9 years total. So there are some data coming out on the patients who've been on Galafold for 9 years, because that's one of the things that the current enzymes have a lot more follow-up data because they're older, right? So it's to be expected. But migalastat does seem to have beneficial effects, at least in stabilizing the kidney function. So that's good. All right. So interestingly, there's some other diseases that are not Fabry disease, but a lot of advances in rare disease. We are all researching rare disease, and we say, well, can I borrow from this disease, right? What did they do in this disease? What did they do in this? How can I apply it to my disease? So in this case, Fabry disease. And it turns out that there's a disease called autosomal dominant tubular kidney disease. And the issue here is there is a problem where things should be targeted to the lysosome, but they don't get there, right? So they need to be in the lysosome, but it's not there. The problem with Fabry disease is that all this stuff gets to the lysosome, and now you have to break it all down. So it turns out that this researcher by the name of Anna Greca for this autosomal dominant tubular kidney disease has a drug that can now traffic this protein elsewhere. So it tells the protein, look, you need to go to the lysosome, right? So as we learn more about this process of targeting sphingolipids and targeting proteins to where they need to be, maybe this is an approach we can take. What if we could target GB3 not to the lysosome, but to the outside, to the blood, and then you just pee it out, right? That would be a completely different way to do this. Now, I'm not saying it's there, but these are the starts of ideas that we can start looking at and are still trying to say, how can we apply this same concept to other lysosomal storage diseases? Now, the way I break up really therapy for Fabry disease in our patients, because in our patients, I become their primary doc, right? So I'm a nephrologist, but most of my patients don't have kidney disease. So I'm just taking care of that Fabry. I mean, literally, there are geneticists that refer to me for their Fabry care because that is what I do in this Fabry clinic. So there are some people that just say, hey, look, if Fabry disease, then enzyme or chaperone, right? But there's so many other things that can be done to help patients. So first of all, if you have significant kidney disease, you should be on a low salt diet. And by low salt, that is less than 2 grams. Now, I heard many people from the South, Texas, Alabama, Georgia, we are not accustomed to eating low salt diets. So I think low salt in Alabama is like 8,000 milligrams, but it needs to be 2,000 milligrams. And what I tell people is when you transition from a regular diet to a low salt diet, it's going to taste bad for about 3 weeks. And the reason it's going to taste bad is you've upregulated the salt sensors in your tongue. So, however, I can tell them if you stick with it at about 3 weeks, your taste will come back. It'll all be normal. And that's because your salt sensors have changed to accommodate the low salt diet. So now if you go back and eat a high salt food or the same food you were eating before, it's going to taste disgusting because it's going to taste too salty, right? But there's a 3-week, hey, look, I got to get this done, right? Now, another thing is ACE inhibitors and angiotensin receptor blockers. So these are important in patients who have proteinuria, specifically more than 500 milligrams. But what people don't necessarily recognize is this is not to be titrated to blood pressure. A lot of Fabry patients don't have high blood pressure. They have normal blood pressure. So a lot of docs will say, well, why am I going to put you on an ACE inhibitor? Your blood pressure is normal. You say, it's because my protein is high. So I need to keep increasing that medicine until your blood pressure goes too low, which is a systolic, that's a top number less than 90, or your protein goes less than 500. you're titrating it to protein, not to blood pressure. Finally, there's some new kids on the block. It's the Sglt2 inhibitors. These are actually medicines that were for diabetes. So SGLT2, it's sodium glucose cotransporter is what the SG stands for. And what happens is if you inhibit this, patients with diabetes start peeing out salt and they start peeing out sugar. So they found that this was a good treatment for patients with diabetes. But it turns out some really smart people said, look, this thing is really doing well for patients with kidney disease. What if we tried it in patients without diabetes, who have kidney disease but no diabetes, right? And it turns out it was overwhelmingly positive. In fact, at the American Society of Nephrology, this was probably like 40% of the meetings was talking about the effect of SGLT2 inhibitors on non-diabetic kidney disease. So it turns out, just like ACE inhibitors and angiotensin receptor blockers, we think that in patients who are maxed out on ACE inhibitors and still have protein in the urine, what I'm doing is starting them on SGLT2 inhibitors, right? But first, you want to go with the easy first, which is get the ACE inhibitor or the angiotensin receptor blocker. Those are the lisinoprils and the losartans. Titrate them to max dose. If that gets your protein less than 500, fantastic. But if you still have a lot of protein and you're on max dose of those, then try the SGLT2 inhibitors on top of it. And I think that we're going to see that it actually benefits people. So in 9 years that I've been taking care of Fabry patients, so far, knock on wood, we have not had one patient who ended up on dialysis, which is pretty impressive when you look at the natural history of Fabry disease. So do SGLT2 inhibitors affect blood pressure? Modestly. They have a much less than ACE inhibitors and angiotensin receptor blockers. But you can expect a little bit of a decline, but most of that is because you're peeing out salt. All right. So new in diagnosis. So there's some other things that I'm excited about. One is gene panels. So there's a lot of gene panels that are coming out. What I'd like to do is, so we get a lot of diagnoses of Fabry disease from hypertrophic cardiomyopathy clinic. These are the cardiologists. And the question is why? And the reason why is that they don't even think about Fabry disease. So I've spent the last 8 years trying to teach people to think about Fabry disease, only to realize that's never going to work, right? So doctors are not going to think about Fabry disease because it's too rare. So what do we have to do? In order to diagnose it, we got to make it so simple that they don't have to think about it. And gene panels are the way to do it. So the way the cardiologists do it, they say, if big heart, send gene panel. That's it. Now, in that gene panel, there's about 150 genes that can all cause hypertrophic cardiomyopathy. One of them is Fabry disease, right? So they're testing for Fabry disease all the time without even thinking about it. And that's how we got to get it. So what I'd like to do for kidney disease, we now have Invitae and Natera both have kidney disease panels. So what should it be? If kidney disease, nephrologists always do a kidney ultrasound. Is just, if you have kidney disease, you get a renal ultrasound. Well, it should be, if you have kidney disease, get a gene panel. Fabry disease is one of those, and we're going to start diagnosing things. Now, the Natera panel has 385 genes. So the reason why docs have trouble thinking about Fabry disease is, imagine if you had a differential of 385 things for kidney disease, and you have to think about exactly which one to order. Well, that's too hard. I mean, it's really too hard. So I think that operationally, we got to start hitting the easy button, and gene panels are the way to do it. So since I'm the medical director of telehealth for our entire health system, and I got there because of home dialysis and rare genetic kidney disease, right? My patients were traveling significant distances to see me. So I said, why can't we make these patients' life better by doing telemedicine? It turns out that's what I did. It took me a long time to get it set up. But in 2017, our health system said, why don't you do this for the whole system? And then COVID happened. And last year we did 280,000 telehealth visits at UAB. So, it went from very small to very large very quickly. But I'm most excited about telemedicine for rare disease because, one of the things that I don't think is fair is, just because of where you're born, you may not have an expert in whatever disease you have right next to you. And that's not right. And so, especially now in the setting of telemedicine. So with telemedicine, the idea is, what if we can see if everyone had access to specialists in their disease? And they didn't have to take off work, spend nights in hotels, et cetera, trying to see them. And that's really why I started telehealth. And so that is what we're doing. I see many patients over telehealth with rare disease. Now, I think people ask me if I like to see patients over telehealth. For me, I like having my hugs and handshakes and things like that. But I don't think it should be about me. It should be how do we meet the patients on their level? So telehealth is going to have a big role in rare genetic in rare disease in general. So these are just the conclusions, which is kidney function needs to be monitored. It needs to be monitored at least yearly. You need to know how much protein you have, and you need to know what your GFR is. Treatment revolves around both Fabre specific and non-specific therapy. So if you have neuropathy, you need to be put on gabapentin or carbamazepine. If you have GI symptoms, there's other drugs that can help with GI symptoms. So you need people that are saying, yes, you need enzyme, or yes, you need Galafold, or whatever specific therapy it is. But you also need somebody that says, what about if I'm still not feeling well? I need other drugs and therapies for that. So kidney non-Fabre specific therapies are just as important. Kidney biopsies are very useful, asymptomatic for females, variants, and really, I think males for baseline kidney function, and if there's a significant change in kidney function. So that is my talk. I'd be happy to take any questions. All right, so I got James Hunt said, at what GFR should a nephrologist start pursuit of kidney transplant for his patient while preparing him or her for dialysis? So it turns out we have, those are actually national criteria. So we are not allowed to refer somebody for transplant until the GFR is below 20. And not just below 20, it needs to be consistently below 20, because it could be that I start you on an ACE inhibitor, you drop to 19, but the next time you're 21. So it needs to be consistently below 20 is what the recommendation is. So now you do need to be referred preemptively. So, hopefully that if you're following as somebody who is a nephrologist and you're following for a long time, they can predict when you're going to hit 20, they get you prepared for both, but they refer you to transplant when you're 20. When you're 10 is around the time you need dialysis, right? Now, the fastest way to get a kidney transplant is to get a living donor, right? So this is when you get to around 25, you may want to start asking friends, family, even complete strangers, right? You say, hey, I have kidney disease. And the reason is we've had patients who actually went to church and had their preacher announce it and they got a kidney. We've had people who have announced it on Twitter. Actually, when I was at Vanderbilt, I think we had somebody announce it on Twitter. Actually, a celebrity found it and retweeted it. And Vanderbilt got, I think, 13 kidneys out of it. So one of them went to that person. 12 other complete strangers decided to donate to other people. So unfortunately, or not fortunately, in today's day and age where there's so much crap in the world, right? You'd really be surprised that humans will surprise you. And living donation is one of those things that it's selfless and it's amazing. But nobody's going to know you need a kidney unless you ask. And I have many patients that they say, I don't want people to know my business. Well, then that's fine, but you're not going to get a living donor, right? So people need to know, give them a chance, right? If they say no, that's fine, right? But if they say yes, great. The other misconception is that I have to have a blood type, right? They have to be a match. That's not true either anymore. And all you need is somebody who is healthy and willing, right? And the reason is if I have a friend, say I need a kidney and I have a friend that's not my blood type, but they want to donate. Well, now there's another person out there who has a friend that has a different blood type. So what they do is they do a swap, right? So my friend donates to this person friend donates to me. And that potentiates really what's called chain donation. So all you need is somebody who is healthy and willing to donate a kidney, right? Very important. So how do I feel about organ donation? I feel so interesting. So it's an interesting question. So this was a direct question about how do I feel about it? I love people getting transplants because transplants are better than dialysis. Now, how do I feel about a Fabre patient So if one of my Fabry patients who had relatively normal kidneys wanted to donate a kidney, if that is known, they would not accept the kidney, right? And the reason is that ethically, when kidney transplant was starting, kidney transplant docs were not viewed very highly. It was actually, all doctors take an oath, which is first do no harm, right? And so when living organ donation came, deceased donor was fine, right? Because you're not doing harm. But living donors were actually viewed very, very differently. And the reason is that they said that patient who you are taking a kidney out of is healthy. You are doing harm by taking this kidney out, and you're breaking your Hippocratic oath, right? Now, it turns out it took a lot of people and probably a lot of yelling, right, to get over that and say, look, if we take out a kidney, these patients do really well if they don't end up on dialysis or if they don't have a pre-existing kidney disease. So what they do when they do these living donor evaluation is they have to say, what is the likelihood of this person who's donating a kidney is going to need both kidneys, right? So what is the likelihood one of them fails? And if you have Fabry disease at baseline, that likelihood is higher than most people would be willing to accept, because now we've just done harm, right? And so that's where all that comes from. So I don't think that patients with Fabry disease should necessarily donate a kidney, but I'm very happy if my patients with Fabry disease get a kidney. Okay, so let's see. We have, are there ways to reverse the kidney damage, improve GFR, N-acetylcysteine and L-arginine, few others to slow down that decline? That's a great question. So the reversal of kidney disease is an interesting one. Most of the time when kidney docs say we're successful, it's that we stop it from getting worse, right? Unlike the liver can regenerate itself, but the kidney doesn't have that potential. So by the time the kidney actually fails, or when it starts going down, there's usually a scar that builds up that you don't get back. Now, interestingly enough, there are some drugs out there that the GFR appears to get better, right? I say that just like that for a reason, appears to get better. And the reason is that you can make the GFR get better or look better. The creatinine goes down. One of the ways to do that is pregnancy, right? And so how does pregnancy make the creatinine go down? And it's because your body starts to hyperfilter. So from conception, your body says, well, look, I'm going to deliver more blood flow to the kidney. So anything that delivers more blood flow to the kidney will make it look like the kidney got better. But in reality, what happens is it's overworking the kidney, right? So L-arginine, for example, so back in the day when we were doing studies on saying, what is the renal reserve? What we would do is we do IV infusions of amino acids like L-arginine. L-arginine actually vasodilates, which means that it just forces more blood through the kidney. But the kidney, the tissue itself, that damage is still there. And arguably, if you hyperfilter, right, if you overwork the kidney, you can actually make things worse. That's what happens in diabetics. So they have normal filtration, then they hyperfilter, and then so the creatinine gets better temporarily until it starts getting worse quickly, right? So there's some other ones that we're using in Alport's disease, and this is bardoxolone methyl. So bardoxolone methyl in diabetics in the initial study seemed to improve the GFR, but most of that seems to be because it actually caused the patient to hyperfilter. So we just got to learn a little bit more. Now, interestingly enough, this Protalix study out of Europe, which actually showed an improvement in eGFR, is not what anybody would have expected. So like I said, I anxiously await the BALANCE trial so we can actually figure this out, what actually happens when you have a head-to-head comparison of 1 milligram per kilogram with both doses. So since transplant patients are immunocompromised and usually don't have antibodies to fight COVID after the vaccine, are there any updates on this? I had my blood test and I have 0 antibodies. That's absolutely, so that's an important question. So interesting, it's important for 2 reasons. One reason is so I don't know if you guys know the story about antibodies to enzyme, right? So in males, primarily in males, right? Which is that well, before I get to that, Randall said, does pregnancy permanently hurt the kidney? No, pregnancy actually usually is fine unless you start the pregnancy with kidney disease. So if you start the pregnancy with a chronic kidney disease of stage 3, you have a 60% chance of ending the pregnancy with worse kidney function than you started. So that was a New England Journal paper. So anyway, back to the the transplant, right? So antibodies, so patients who get enzyme, that's completely new to males, right? So males have 0 protein. Most females have a little bit, but males have 0 protein. So when I infuse a protein that they've never seen, the immune system says, hey, I got to attack it, right? So they develop antibodies to it. And it turns out that these antibodies, if they inhibit the enzyme, can be bad, right? We don't like antibodies to attack enzyme that we're using to improve things. So one person said, well, look, why don't we just test Fabry patients who are on immunosuppression for their transplant and see what happens to antibodies? And it turns out that if you had pre-existing antibodies and you got a transplant, the antibodies didn't drop, right? Didn't really do anything. Interestingly, if you got started on enzyme when you were already on immunosuppression, you didn't develop antibodies, right? So just goes to show you that immunosuppression does reduce your chance of developing antibodies, which brings me to the question here, which is what about the COVID vaccine, right? So it was not shocking to think that patients who were transplanted did not mount the same immune response to the mRNA vaccine as non-transplant patients. Interestingly enough, even without immunosuppression, patients with end-stage renal disease don't mount the same immune response that patients without renal disease do. So there's something about the kidney, there's a crosstalk between the kidney and the immune system that we don't understand fully. Now, that withstanding, what do we do about it, right? So now it ended up in that one study, I think it was out of Hopkins, it was about 40% of patients with transplant did mount an antibody response. 60% didn't. Does that mean you're not protected? We don't know, right? It could be that just the way we're testing for antibodies isn't good enough. In the ESRD population, let's take the example of hepatitis B vaccination. What we do in those patients who don't respond to a series of hepatitis B, we give them more, right? So the question is going to be in transplant and in the ESRD patient population, do we give them boosters? So you got your 2 vaccines, but maybe you need 2 more vaccines to actually mount this response, right? So that's what people are learning now. I mean, COVID is only a year old. I mean, this is baby time in the amount of time it usually takes us to do randomized controlled trials. Then we do the trials and then we fight amongst each other and then we do more trials and then we fight. I mean, it takes 10 years for this stuff to develop. So, so it's still new, but I think that ultimately what's going to happen is we'll probably have to revaccinate and give more series before ESRD and transplant patient actually develop the full response. Any other questions?
Great. Thank you, Dr. Wallace. That was great. Any last quick questions before we do the last 2 things? All right. Thank you very much. I have a few announcements to make. And Dr. Wallace has already given us a great prep for my slides. So I'm going to share my screen. 1 second. Whoops. I hit share and the whole thing went away. Hang on 1 second. Try that again. Slight technical difficulty. Give me 1 second. Oh, here we go. All right, can everyone see that? Or someone that is unmuted, can you see that?
Yep, I can see it. And I see you're put in slideshow. That'll be great.
Okay. So I just have a few slides, and each meeting, I'd like to take an opportunity to tell you what's going on with each of the industry programs, which Dr. Wallace just did a great job with that. But I'll let you just briefly see the slide. And this slide will be in the recording also. So if you want to go back, and the main thing this slide does is it tells you either a particular website that the industry company would like everyone to know about, or how to, in Amicus and Sanofi's cases, that's what it is, their websites. In Casey, they have a new website called Rethink Fabre, which is interesting. And as Dr. Wallace mentioned, the various clinical trials that are ongoing for Averbio, Sangamo, 40MT, and Freeline. And there's information on each of those. Then, of course, Idorsia, he talked about with the substrate reduction therapy. So this slide is available for you to go back and use, get any of the information off it that you would like in the recording. Let me go to the next slide. And the next slide is how you can get to each of the companies on our website. So if you're on our website, you look at the top menu bar, scroll down the company clinic information, go to pharma company, and below you'll see examples of, in the left box, examples of each pharma company has a grid square. And in the bottom of that grid square, it says read more for the resources. And it'll give you other things that each of those companies would like you to see, informational resources mostly, of some of the products that they think are beneficial for people with Fabry disease to have. There's a clinic info tab also that I don't have shown here, but it's just got a couple of clinics in it. And then support organization tab is the last one. And in there, you'll have a couple of tabs by the National Fabry Disease Foundation, ourselves, the financial assistance programs, and a few other things. So just to let you know that that resource is available if you want to find the information and the company's contact information. The next slide is we still have plenty of calendars, Fabry symptoms educational calendars left. So if you don't have one already, you attending this meeting should trigger a calendar, us sending out a calendar. And if it doesn't in a short amount of time, then email me and tell me you'd like a calendar. And the last thing is just each time, as you probably already know, when we finish one meeting, we disable the registration link and then we enable the next one. So in a couple of days, you'll see the next meeting registration link enabled. And you can always go over to the last tab in here. And after a couple of days, the recording will be up. So you can't see it on this screen, but after sponsors on the top menu bar, you'll see archives recordings. Go in there and it'll show all the past meetings. And there's this is the 8th one now. And you'll see the 7 recordings up there right now. In a couple of days, you'll see this last recording up. And we'll just continue until we finish the series in whatever 8 is from 21, 13 left. All right. Anyone else have any comments? Dr. Wallace, thank you again. Dawn, thank you very, oh, one more thing to go. What's the word for the prize drawing, Dawn? I'll stop
I
there.
think the word is kidney. So go ahead and put kidney in the chat and we'll, our lovely Vanna or Brenda will tell us who wins.
Again, this is for people with Fabry disease, family members, and caregivers. Put kidney in the chat box and we'll do a prize drawing. So while Brenda is looking at all the input, in a moment, she's going to use a random number generator to assign all of you a number, put it in the random number generator. It'll give us a response and that will be the winner. And we send out a $100 Amazon gift card to the winner of the prize drawing for your participation and support. And Stefan, Stefan has been a lucky winner twice already, so we'll see how he does tonight. so much anticipation. Go, Brenda, go, go, Brenda, go.
I'm trying to go fast.
Sent is here.
Oh, no, I'm just making some noise while you're looking for the prize winner. Usually what I do when we have a moment of silence here is talk about the progress of my heart transplant. And so I am at just over 8 weeks now. I have not had any heart transplant rejection or heart rejection, and I've been doing very, very, very well. And so I'm just feeling healthier and better every day. And pretty soon I'll be my good old self. Before, actually better, because now I can have more energy and more, my lungs are in better shape, and my kidneys took a little hit in the transplant, but they're coming back.
That is great news. And other great news is that our winner is James Hunt. James,
Hunt.
congratulations.
Well, congratulations, James. We will send you a gift card. And thank you once again to everyone for participating. Thank you, Brenda, Dawn, and Dr. Wallace, and we'll see you all next time. Have a good evening.
Thanks, everybody.
And Brenda, you and I and Dawn are going to stay, aren't we?